come to the last talk of this symposium. The next topic is I Don't See Red But the Microscope Does by Professor Dr. Khong Su-Yen from, she's a consultant urogynecology from University Malaya Medical Center. Prof. Khong has started urogynecology service as well as helped expand the laparoscopic services of gynecology patients at University Malaya Medical Center. She worked in close collaboration with her team members with obstetric and gynecology as well as other specialists, in particular with the colorectal and urological colleagues in the management of complex pelvic floor dysfunction problems and severe endometriosis. She is also actively involved in the training and supervision of under and postgraduate students and has been a member of the conjoint board of examiners for the Malaysian Master Program in Obstetric and Gynecology since 2011. She is also an international faculty member of CAG Center in Sydney and have regularly been invited to facilitate laparoscopic and urogynecological workshops. Her publications include book chapters and papers in peer-reviewed medical journals.
Thank you so much for your kind introduction. Thank you for inviting me to be a speaker here to the organizing committee. And good morning, everyone. So I've been given this topic of I don't see red, but the microscope does. And of course, it's probably not, well, suited to be in a session of incontinence. I think if you had hematuria with incontinence, I think certainly talking a lot about a more serious matter. So I'm basically going to talk about management of asymptomatic microscopic hematuria, and of course, us being urogynecologists in the female. So I'm going to refer this to AMH for the rest of my talk. So what is hematuria? I mean, it is a very common urological problem. It just basically means blood in the urine. It could signify a potential underlying serious condition. And this could obviously be a urinary tract malignancy, anything from the kidney, ureter, down to the bladder. And it could be due to stones, and of course could be due to a medical condition, due to a renal problem. And of course, it's very different in terms of how we manage these patients as to whether we are dealing with macroscopic, gross hematuria, or microscopic. So in my talk, I'm going to concentrate on AMH. So what's the prevalence of AMH? It's been cited in literature in multiple studies, and the range goes from anything from 2 to 31% if you were to screen the healthy individual population. Okay? But overall, the risk of you getting a urinary tract malignancy is only from about 2 to 5%. And majority of these individuals who do get diagnosed with a malignancy actually have a lower urinary tract malignancy. We're talking about bladder. So to get a kidney cancer is really very rare. So I looked around at the guidelines. I actually, when I was preparing for this talk, asked my urological colleague, do we in Malaysia have a guideline for management of AMH? And the answer was no. And when I looked into what was in the literature, I came across this very helpful publication. And this was actually published in the British Journal of Urology International in 2017. And this actually looked at the guidelines among various countries in the world, and they called this the guideline of guidelines for AMH. But of course, when you review guidelines, what they found was that unfortunately there was no consensus for majority of what they were advising. There was a huge variation because of the lack of level 1 evidence. We don't have this. So there was a huge variation as to what the definition of AMH is, what is the age at which we should start doing investigations? When should we evaluate further? What is the criteria for referring to our nephrologist? What diagnostic tests should we use? And also, how should we follow these patients up long term? Of course, in a short period of time, I cannot go through all this in detail, but I'll just give you a little summary. So I'm just looking at the definition that was given by the Americans. So the American Urological Association said specifically that we should not be using dipstick urine because this gives us a high false positive rate of up to 35%. And they specifically said that the evaluation should be based solely on microscopic examination, and they define this as more than 3 red blood cells per high power field, and interestingly, only based on 1 properly collected sample, so a midstream urine or a catheterized sample in the absence of benign cause, so infection, trauma, and so on. Then with the British Association of Urological Society and the Renal Association in the UK, they actually use the dipstick, and they define AMH as 2 out of 3 positive dipsticks, and it recording as equal to 1 or more plus. And with the Canadians, they then also defined it as quite similar to the Americans, equal or more 3 red blood cells per high power field, but based on 2 separate samples. So I know this is a rather busy slide, but it's just really to look at the paper that quoted, guideline of guidelines. So they looked at many guidelines. This is just the first page. There were 2 pages. And I'm not quite sure whether you can see much, but basically Americans start screening above the age of 35, the Canadians above the age of 35. The UK, in fact, have now removed their guidelines from the website, and they're now basing it on the NICE guidelines. And they only take individuals seriously if they're above the age of 60 with either dysuria or the presence of white cells in the urine. So, from 35 to 60, huge variation. And with the Japanese, I think we've got many Japanese eminent professors, I think, in the audience. But correct me if I'm wrong, but they quoted as more than 40 as the age threshold for investigation. And as to when to evaluate further, majority of these guidelines did not state an age. And as to when we should refer on for nephrology referral, again, there was a variation. So then, what about what investigations, what evaluation, what imaging should we be using? Again, there was a big variation among the guidelines. So I'll go on to this a little bit further. So I've just taken one of the guidelines, in fact, the most comprehensive, and this is the American guidelines. And I'm not sure whether this applies. So what they did was that, as I said, the definition was that if you had a microscopic analysis of less than 3 red blood cells per high power field, then you don't need to do anything more. But of course, if it tested positive for that, you should be going on to do renal function tests. And if that was negative, nothing else needs to be done. But if your renal function test came back abnormal, okay, then you should be then referring them on to nephrology referral. And this says if they're negative, okay, or positive, they have to go down this route. So all women or patients should be assessed for risk factors for malignancy, and I'll go on to table 2 to list what they deem as risk factors in a little while. Whether they then be assessed the individual for any contraindications for radiation, contrast media allergies, or any evidence of renal insufficiency. Because if you've got any of these three down here, then you may then have to reconsider as to whether you use contrast with your imaging studies. If you did not have any of these allergies, then of course what they deem to be the gold standard in America in terms of imaging would be to go on to do a CTU urogram. Now, if you did have, for example, contrast allergy, then they did say to reconsider and obviously think about using MRI, renal ultrasound scan, etc. to investigate your individual. All of them then should then go on to have a cystoscopy, and I will go on to talk about that in a little bit as to how you should follow them up if they were to have a negative cystoscopy. Of course, if they had a positive finding on cystoscopy, you would treat appropriately. So let's go back. We are all clinicians. How should we assess the patients? So we should always start with a good history. So document the age, what occupation. Now the occupation really plays a role here, because of course if the patient has been exposed to chemicals or dyes in their work, this puts them at a high risk. Is the patient pre or postmenopausal? Of course here we're thinking as to whether there's any evidence of atrophic vaginitis. Symptoms-wise, does the patient have significant lower urinary tract symptoms? Any evidence of prolapse? Is the patient a smoker? And of course, we have to take into consideration whether they've got any significant medical or surgical history. And lastly, drugs. Are they on any antiplatelet drugs or any anticoagulants? Clinical examination, always remember to take a blood pressure, complete an abdominal and pelvic examination. And from the laboratory test point of view, we should be including a serum creatinine as well as an estimated glomerular filtration rate. We should test the urine for proteinuria, and they said a spot protein or albumin creatinine ratio was more than enough. You don't need to do a full 24-hour urine collection. You should also be looking at any evidence of cellular cast or dysmorphic red cells. And of course, if the patient also had hypertension, all this has to be taken seriously, and an urgent referral to your friendly nephrologist should be your next step. A diagnostic cystoscopy is to be carried out really, and this was one thing that all the guidelines came to a consensus. If you have excluded a benign cause for your AMH, then this should prompt an urgent urological evaluation, which should include cystoscopy. And it doesn't matter as to what your age threshold is, you should investigate. So a little bit about upper tract imaging, and this is where there's quite a lot of non-consensus, if you want to say that. Because I think in Japan, they have advocated doing a renal ultrasound scan as the first line, but the Americans have chosen not to go down this route because they said that studies have shown that it's only 50% sensitive, which is not good enough. So they have actually opted to do a multi-phase renal CT urogram with a sensitivity of 91%, with a specificity of up to 97%, so much higher. But of course, we must bear in mind that you obviously have got the costs to deal with, but also, of course, some of your patients may have severe allergies to contrast. The other suggested imaging modalities were the MRI with urography, and they've suggested that perhaps if you really needed to investigate a pregnant patient. We could also use non-contrast CT, and lastly, to do a renal ultrasound scan in combination with retrograde pylorography. Then I thought, well, it's getting a little bit confusing. You know, there's so many things that, you know, different people are saying different things. So I actually came across this publication in JAMA by Halpin, and that was done last year in 2017. And they're actually Americans, so they're actually looking at the cost to the Americans in terms of advocating CT urogram for all their patients. And you must remember, only with one positive sample that's testing positive for AMH. So what they did was they looked at 4 common diagnostic approaches. So if we were to look at just CT alone, it was costing them 9.3 million. And with that money, they were detecting 221 cases of cancers. We're talking about urinary tract cancers, okay, upper and lower. If you just did cystoscopy, it was not too bad. You were still picking up 222 cases for a much cheaper price, 2.2 million, okay? But if you were to do an ultrasound scan of the kidneys and combine this with the cystoscopy, you were picking up an extra 23 cancers for an added cost of 3.5 million. So what they've looked in here, ICCD, is actually incremental cost per cancer detected. Okay? So if you added on ultrasound scan to your cystoscopy, it cost you an extra $53,000 to detect that one cancer. But if you were to replace that ultrasound scan with your CT scan and the cystoscopy, which is what they're performing now in America, you only pick up an extra 1 case for an extra 6.4 million per cancer detected, costing the Americans 11.5 million USD. Okay, so from this, it's actually very interesting. They're now with this thinking, maybe we should be relooking at our guidelines. Okay, maybe CTU may not be the way forward. Maybe we should be replacing this with a renal ultrasound scan and a cystoscopy. What about urine cytology? Well, it's not recommended, and that was stated by majority of the guidelines because it's been found to have a low sensitivity of only up to 48%, but unfortunately, when it tests positive, it may lead to emotional stress and unnecessary biopsies in false positive cases. But when may it be useful is when you've got cases of persistent AMH after a negative evaluation, or in those of whom have tested high risk for cancer. All right? And of course, definitely indicated if you've got evidence of macroscopic hematuria in or your high-risk cases for bladder cancer. So what about follow-up? If you've had a thorough investigation for the AMH and everything has come back negative. What all the guidelines have shown is that you should not discount this. You should recommend ongoing follow-up because you're still uncertain of the underlying cause. And you should definitely monitor the patients for any voiding lower urinary tract symptoms, any visible hematuria, so from microscopic becoming macroscopic, and whether they've got increasing proteinuria with time, do they have a deteriorating renal function, or certainly if they start developing hypertension. And you remember that rather big, complicated algorithm I showed you earlier by the Americans? Well, this is a continuation. What should we do if they've got a negative cystoscopy? So what they've done here is that if you test positive, it's pretty obvious that you should do whatever is appropriate to treat the cause. But if they were to test negative, they advocate doing an annual urinalysis for the next 2 years, and if that came back negative, then to discharge the patient. If it came back positive, all right, and you still haven't found the cause, you should continue screening the patients on an annual basis, and not just with the urinalysis. If it was persistently positive, to actually repeat your anatomical evaluation within the next 3 to 5 years. So what we mean by this is repeating your imaging studies. So I think one of my last slides, I think just to summarize, I know I've concentrated with the American guidelines, but that seemed to have been the most comprehensive. So there's no sufficient evidence now to recommend screening urinalysis for detection of bladder cancer in the absence of clinical indicators. That further evaluation is recommended for individuals with 3 or more red blood cells per high power field in a properly collected urine specimen in the absence of infection. That you should do concurrent nephrological and urological referral in the absence of hypertension, elevated creatinine level, dysmorphic red blood cells, cellular cast, proteinuria on urinalysis. And the CTU, as it stands, is the preferred method for radiological imaging in the evaluation of microscopic hematuria, and urine cytology and other bladder tumor markers are not recommended for the initial evaluation of AMH. So really, in summary, there is obviously a significant variation between the guidelines, and this is all because we do not have good level 1 evidence. There's certainly, I think, a huge difference, I think, in the level of prioritization across the healthcare systems across the world, worldwide. And of course, we always have to bear in mind the cost implications whenever we do screening and how we subsequently manage a patient. So further research really is required to improve diagnostic tools, to actually look at our workup methods, look at our methods of diagnosis, how we should follow up these patients long term, and really with this, hopefully come up with a risk stratification and a triage, a way of triaging these patients to actually improve the outcome to these patients. So I think with that, thank you very much.
Thank you, Prof. Khong, and very informative lecture. I learned so many things from your lecture. Thank you very much. So, and do you have any comment and question on the floor? Oh, yeah. So all speakers come up to the stage, please. And also, yeah. Yeah. Excellent seat. Yeah. 1, 2, 3. Okay. 3 speakers sitting here. Okay. Do you have any comment and question on the floor?
Question? Okay. I'd like to know. Thank you for the wonderful lecture. I'm Dr. Ng from KL. I'd like to know the role of double anticholinergics and which group do you use? Double anticholinergic. I saw there's mirabegon, darifamycin. Because I have a patient who only responded half. What's the second anticholinergic? To control the OAB. Because we have similar problem. They respond half, but I saw this just now there's darifamycin and mirabegon. We want to use 2. Must it be 2 different groups or the 2 same group? Could it be 2 same group?
In the refractory to one medicine for OV anticoagulator, some cases I will try about 3 months later. If you refractory one medicine of anti-muscarinic agent, sometimes I will try 2 tablets. I mean 2 different tablets. Yeah.
Could it must be this different group, like mirabegon is a different group compared to the rest, which is all anticholinergic. Must it be 2 different groups? Could it be 2 same group? Because our next option will be Botox. So could these 2 medications of the same group, for example, you can get darifamycin with trospium, or darifamycin or trospium with tocorodine, instead of, must be another group. Like mirabegon is a group by itself. Could it be the same group, the 2 anticholinergics?
But in all patients, if you try use the 2 tablets about the OV anticoagulator, some have a side effect because the accumulation in old patient, we should be careful.
Okay. Because my problem now is some patient responds half. And that is the maximum dose we could give. So what my problem is that can I start a second anticholinergics? So especially not for older patient, maybe in between 60 to 70. That means we can start the two anticholinergics of the same group. Okay, thank you.
Okay, I'm Dr. Zalina from International Islamic University. I have two questions to the first speaker regarding the stress-free incontinence. Since now we are in the era of meshless, and we are having difficulty in using the mesh, how about the role of bulking agent in treatment of urinary incontinence? I heard that it's getting popular in UK. Number two is that if you are going to do a cervical slings, what type of fascia that you recommended? Is it better from the fasciolata or from the rectus sheath? Thank you.
The first question is about the bulking agent injection for the SUI. In practical, because the time limit, I not showing this slide in my speech. Because the procedure is not common use in Taiwan, especially for the urogynecologists. Because the injection is temporary and the side effect is very common, and the effective rate is very low. And in our research, some case series is it have a very short cure rate time. So it's only for the refractory to the other therapy or more medical condition good for invasive surgery. We also consider injection therapy, bulking therapy. Next question is
regarding the cervical sling.
Yeah, it's
Which
abdominal.
part that you would like to have a
Yeah.
mesh? Is it from
We
the
second
rectus
use
sheath?
is because we drop back to the older surgery. In general, the sling is from the abdominal fascia. We give the transverse incision and give the 10 centimeter length and about 1 to 2 centimeter fascia from the abdominal fascia to give the from the pubic to the vaginal root to press the sling in the neck position.
Thank you very much.
Thank you. Yoshi will do the last question.
Last question. Yosh from Japan. Well, my question is about mid-urethral sling. Well, as Mr. Su showed us in the morning lecture, well, it's crazy. They give a mesh utilization in incontinence surgery. It has concrete evidence. So why did they abandon sling material in anti-incontinence surgery? So I'd like to know the condition in Asian countries. In Japan, very rare to abandon PP mesh in anti-incontinence surgery. So what about the condition in another Asian country?
Do you have any comment from maybe Malaysia?
I will comment, Professor Yoshi. I think it is a disastrous era that we're in. I think, you know, the mid-urethral sling, I think, is one of the most tested device that we have, and we have good evidence from 20 years of studies. And I think the fact that they are actually now translating all the concerns from a vaginal mesh to an incontinence tape, I think, you know, it's doing our women a huge disservice. I mean, you know, with all the scaremongery that's going on, I mean, you know, and it's already happening in Australia, in the UK, etc. Women are actually coming to clinics saying, I refuse to have a TVT, I want to have a copal suspension, or I want to have a rectus fascial sling. But I think they've forgotten, obviously, why we have developed a sling in the first place. That's because we were having complications from all these problems 20 years ago. And I think as urogynecologists, I think we really, and urologists, we really have to stand firm on this. Because, you know, we cannot, you know, have something so useful and that's been proven to be efficacious with good clinical outcomes be taken away because of all the medical legal issues that are going on with vaginal mesh, not sling. They should not be translating all that. So, and I think in Malaysia we are continuing to use slings, and I think most of it is, yes, some patients come and say they Google and they're scared, but I think it's very much our job to reassure them and to give them the evidence that we do have. And I must say that that hasn't been an issue. My patients have continued to allow me to put slings in them. But of course, yes, with, you know, all of us know everything we do, there are risks. But it's balancing the risks and also getting the benefits. So, sorry, I feel very strongly about that. And in fact,
okay, Dr. Su will conclude this session.
I believe I'm the last one to conclude this session. I'm quite interested in you want to use the mid-utility in the near future. If you can go back the history of the treatment models for SUI, we start from the STEMI operation. That's so-called the use the suture to push up the bladder neck. And also we push up the so-called the vaginal method. That's the most standard procedure is copal suspension. And also if it's not works, then we transfer to the rectus sling. That's more complicated. We also use the cystoscopy sling in the early age. That will be 30 years ago. That's a common practice. Until the 1996, the TVT invented. That's supposed to be the best one. Up to now, I would like to say that. Why FDA suggests not to use mid-uterine sling? That's similar to the situation of transvaginal mesh, because the communication comes from mid-uterine sling is not rare. That's similar to the transvaginal mesh. These instances even much more than those of transvaginal mesh. That's the reason why FDA suggests to be careful to even to use the mid-uterine sling. But you can look at the culture of doctors who practice in States, even UK, because there are a lot of general practitioners that like to use this mid-uterine sling, because some of GP today, they just go ahead and training on this field. Then they will do maybe 3-4 cases of operations, because they are lack of good training. Therefore, they cause of a lot of complications, particularly for mid-uterine sling. It's easy and have common practice in the general practitioner. Therefore, cause a lot of complications. But from the action plan of the Committee of Urogynecologic Flow of Fecal, the outcome or the comments or the guideline from all the world is different between mid-urethral and transpersonal mesh, because the mid-urethral sling cause marvelous complications. Also, the effectiveness are quite promising. Therefore, in the advices from the fecal, it suggests mid-urethral will be okay to treat SUI. That's the result. I'm sorry that I cannot have enough time to detail to these advices. Therefore, at this moment, although some of the just only in this world, only I believe that in New Zealand abandoned the visual sling. I don't like to say that is stupid, but this is true. So up to now in Taiwan, we have done a lot of the visual sling that up to 1,800 cases per year. Therefore, for this, I like to suggest this mid-urethral will be a promising procedures. If your country law is okay for these procedures, you can go forward. No need to abandon these procedures. But you should be very careful if for the case selection or the permit consent, even the audit. That's my suggestion. And hopefully, this pen will be released by the data. That's my suggestion.
Terima kasih all speakers and commentators.